My name's Kate Hilton. I work with Marshall at the Leading Change Project at the Hauser Center for Nonprofit Organizations at Harvard University, and I'm also the Director of Organizing for Health. I'm going to tell you a little bit about Organizing for Health and also our partners in Rethink Health, just to sort of ground you in what it is this project is about. But before I do that, I'm going to also tell you a little bit about myself and my own calling to organizing in health. I'm originally from Madison, Wisconsin. My mom was a Missouri farm girl. She grew up to become a Franciscan nun and worked at a hospital run by the nuns in Madison, Wisconsin, where she met my dad, who was a general surgeon. He was born in 1926. He grew up in the Great Depression, and he was a pharmacy mate at a naval hospital in World War II. He was the 11th doctor on staff at the Dean Clinic that grew to 500 during his career. And when he retired, he and my mom, who was later then a hospice nurse, co-chaired a capital campaign for $10 million to build the first Madison Hospice Care Center in our community. And he would go from provider to get providers on board with the effort. And he would say, hospice care is about you. Hospice care is about me. It's about all of us. We're all going to die. We're all going to get sick. There's going to be a point in our life where we're not healthy. So I believe that that statement applies to our health. Our health is about you. It's about me. It's about all of us. When I was a law student, I had an undiagnosed disease. I had so much severe pain from inflammation of my gums, of my joints, of my skin, that I was bedridden. My mom had to help bathe me and clothe me. I couldn't go to class. And through visiting my doctors, they prescribed a drug called Enbrel, which potentially was going to transform my life back into a productive law student, except that my student health insurance didn't cover it, and it cost $2,000 a month, and I was putting myself through law school. So I did what any good organizer would do. I had worked with Marshall when I was a divinity school student at Harvard, and I recruited a team of law students, my parents, my law professor who taught contracts, a judge that I had interned with, and I asked them to work with me to put pressure on my insurer at the university to cover Enbrel as part of my plan. That's what I paid insurance for. Not only did we put pressure on them to cover me, we put pressure on them to cover every student under this plan that needed Enbrel. Because again, health is not just about you and me, it's about all of us. So I'm here because I know from a patient standpoint that if you build a team around you to achieve a shared purpose based on shared values, it can transform lives because it transformed mine. And I know that we in this room know what my dad said about hospice applies to health, that it is about all of us. We know, as Maureen stated in her opening address, that we're spending 2 times as much than any other country in the world per capita on cost, and we still don't have the safest system. We know that our system is fragmented. We know that we can do better on infant mortality rates. We can do better on children's health. We can do better on life expectancy. We can build healthier communities. We can lower obesity. We can lower stroke rates right here in South Carolina. And we know we have a choice. Maureen presented us with that choice to create, to innovate, and to work together to develop a new system and a new design for what health means. Part of this is what Marshall discussed. It requires the development of leaders to lead together in a different way. Leadership doesn't just happen out there, it happens in here. And leadership for change, the change doesn't just happen out there, it happens in here inside of ourselves. So Organizing for Health is one effort under an umbrella of efforts, not just in South Carolina, but across this country, focused on achieving the triple aim. It's an action research project, and it is focusing on work with patients and their families, churches, teachers, our communities, as well as providers and payers and employers, all of us to come to the table to work together to look at our system and imagine what health and well-being should really be for ourselves. As Marshall discussed, organizing provides a system of how to get there. We can imagine what the solutions are. Maureen confronted us with some of those this morning. We have examples from Sweden. We have examples from Grand Junction, examples right here in South Carolina with the South Carolina Partnership for Health, and McLeod Hospital's work on utilizing the checklist. We have ideas in our own communities and our own hospitals and organizations of what we're striving for, and we know what we have to do, and the question is, how will we do it? Some theories of change are effective working from the top down. Organizing offers a theory of change that works at all levels, including the bottom up. And so before I talk a little bit more about organizing, since Marshall did a really good job introducing the concept of organizing, I just want to share with you, how did we even get involved? How are a bunch of organizers involved in organizing in health in South Carolina? And like anybody, it's because we were asked. Just like we will be asking others in South Carolina to join us, somebody asked us to join them. And that somebody was the Fannie E. Ripple Foundation and the Rethink Health Initiative, which is funded also by the Fannie E. Ripple Foundation. It's a collaborative group of folks, an effort that began in 2007 of diverse leaders, thinkers, and doers who are now working together and have committed to at least a minimum of 10 years to work towards changing our nation's behaviors and systems in health. And the Rethink Health group has recruited people like Marshall and also others in different examples of where they've created change outside of the healthcare environment and thinking about how those examples could then be applied within the health and healthcare sector. So these include folks like Peter Senge, who focuses on taking system theory and translating that into organizational change. He's at the Society for Organizational Learning at MIT. Or Eleanor Ostrom, who's the 2009 Nobel Prize winner in economics, who's focused on managing the commons and is now thinking about how to think about health and health resources as a common pool resource and what we have to learn about managing common design principles as we think about redesigning our health systems. So we're working alongside folks like Eleanor and Peter in thinking about how to change health around the triple aim across this country as a movement. And Organizing for Health specifically is focusing on the organizational aspects within our communities. All of us in the Rethink Health group share in common a focus on the triple aim, working across organizational boundaries, relying on systems thinking to drive new structures, practices, and policies, engaging individuals, all of us, in our own shared responsibility to achieve the triple aim, so what that means in our daily life as well as what that means in our organizational life. And then finally, working at the regional level to build a national vision through regional leadership efforts and examples from which we can draw. So as Rick indicated, the Organizing for Health group has selected 2 project sites to pilot our efforts. One is in Manchester, New Hampshire, and the state of New Hampshire. The other is in Columbia, South Carolina, and the state of South Carolina. And we chose these states because we're looking for a state of readiness, a place where, as organizers, we saw that there were folks who are already really committed, number one, to the triple aim, to collaborating with one another across organizations. So just this morning's announcement of the Partnership for Health is a great example of what you guys are already doing around partnering between payers and research and providers. And folks who have a commitment to learning, who want to try new things and to get to the solutions because the commitment to the solution is what drives you. So organizing itself is then equipping these constituencies, these diverse constituencies of our communities, families and patients, teachers and churches, providers, payers, and employers, with the power, which is it's the power that we have in the resources we have, not only in our organizations, but in our own lives, of the choices that we make and the stories that we tell and the strategy we take to get us to real measurable outcomes around the triple aim. So since Marshall did a really great job introducing the concept of organizing, and there's a little picture of Marshall, the methodology that we used was adopted by the Obama campaign in the election in 2007, 2008. So here's Marshall, New Hampshire, working through the various leadership skills that he described when he spoke to you. And again, the leadership definition that we use is what Marshall suggested. It's accepting responsibility to enable others to achieve purpose in the face of uncertainty. And so just to sort of walk us through, what does that really look like? We're pretty familiar in healthcare with the hierarchy model, which is can be a very efficient model. It can also, depending on which direction those arrows are going, if they're not going back and forth, if we don't have communication within the hierarchy, we may disable one another from achieving outcomes. I think the surgical checklist is a great example of that within ORs. We have what Marshall described as the diva model, so one person who's the star of the show, the captain of the ship, who takes on everything and doesn't let others help him or her, to the detriment both of that person's ability, but also of others disappearing because there's no role for them to actually work together to achieve any shared purpose. That's not the model that we're proposing. We're all leaders model, the idea that all of us, we all have a great vision, and we do suggest that we build and develop leaders in everyone, but not so that we all go in our separate directions, so that we work collectively in interdependent leadership teams to achieve purpose together. And that you'll notice the arrows here going in both directions, and that's what we're striving for in organizing, is working, and we might have different roles on a team. You can imagine, for example, in an OR, we have different roles in the OR, but we work together to achieve the safety of the patient. So this is the idea of interdependent leadership, and we have examples of that. We have examples of that in quality improvement efforts. Again, McLeod Hospital and Dr. Michael Rose pioneered using the organizing model to not get folks to adopt the checklist from a compliance standpoint, where they're told to use it, but from a commitment standpoint, where they're sharing with one another on OR teams their call to health, their call to leadership in caring for patients, building relationships with one another and making mutual commitments to use the checklist based on those relationships. We can imagine this system based on the partnership for health among people who want to collaborate with one another across hospitals, insurers, and research to improve outcomes for people in the state of South Carolina. And we can imagine it in our communities, like Maureen showed us with the idea of walking bus or cooking classes and ways in which we can enable one another and our own families to be healthy. We can imagine it in South Carolina. We hope you can imagine it in South Carolina, and we're asking you and your vision team to imagine it and to work with us, and we hope we have something to offer in achieving it. So we're going to actually go into one of the 5 leadership skills with you. We're going to actually ask you to practice it together with us. And so I'm going to invite my colleague Terry Jowers, who's the lead organizer here in South Carolina and member of the Organizing for Health team, to introduce herself as well as the first leadership practice.